So let's move on. Let's move on to Dr. Vikram, who will tell us about early intensive treatment in AMD. You see, both these words are very significant. I hope
Yes.
Vikram will address why early and why intensive.
Yes, I'll do my best, sir. So, very good afternoon to everyone. So, as I said, thanks to AIOS, thanks to Novartis for holding this session. So, my topic is early intensive therapy in neovascular AMD. So, this is, of course, a Novartis-sponsored session. So, as sir was saying, why early and intensive? So, AMD is a progressive disease. We all know that. It is not only progressive, it is a very blinding disease. And it can cause blindness in a rapid amount of time. Let's say it can cause irreversible damage in a short period of span. So early therapy is very crucial. So a delay between the first reported symptom and anti-VEGF therapy has been shown to be a significant predictor for poor visual outcomes. A 2.6-fold increase in the risk of poor vision with a delay of more than 21 weeks when compared to when the treatment was started for 7 weeks. So also eyes in which the treatment interval was for more than 5 weeks initially, that is when they were not treated intensively, they ultimately required a longer time to achieve disease quiescence and required twice as many injections over time. So that is why for preserving the vision, early therapy is very crucial. And for sustaining and having lesser number of injection, increasing the durability of your treatment, giving intensive therapy early is very crucial. So rationale for early intensive, of course, we want a rapid VEGF suppression, which will reduce the retinal damage, improve visual outcomes, and will ultimately lower the treatment burden. So as we were also discussing what is the treatment landscape, we almost now 20 years of anti-VEGF era, and now from the first generation, we are moving towards the second generation, that is the brolucizumab and faricizumab, which prove to have longer durability than the previous class. Biomarkers of treatment response, we all know that we depend on clinical findings, imaging findings clinically. If there is any visible heme, PED, we want to do OCT, of course, is the standard of care of looking the disease activity, SRF, IRF, SHRM, FEPD, and other tools like OCTA, FFA, ICGA also help us in monitoring the disease activity. So treatment strategies, that was my talk also, okay, what were the treatment strategies? So we know that there are 3 treatment strategies widely popular. One is, of course, fixed dosing, where you give loading dose and then you continue monthly and bi-monthly injections. But this is, of course, not practical in real world. It can only be done in the studies. It's totally impractical. Next is what is most commonly followed in our country or in most of the world is PRN. So here you give a loading dose and after that as and when needed. But the pitfall of this is that it's a reactive approach, and sometimes it causes almost 40% of the patient get vision threatening recurrences with this, and they can lose vision. So treat and extend is the best modality, which has incorporates both of them, that you give the loading dose till the disease is quiescent, and progressively, rather than giving fixed monthly, you progressively increase the treatment interval so that you reduce the number of injections and the disease remains in the maintenance dose. You are continuing the maintenance dose and the disease is quiescent. So this is, of course, this is known as a proactive approach, where you don't want the disease to be active again. So best strategy, of course, a number of trials have shown that treat and extend and monthly regimens are definitely superior to PRN dosing for the points that we discussed. Treat and extend significantly reduces treatment burden and is non-inferior to fixed dose regimen. So you don't need those many number of injections. And as I earlier also said, that 50 to 70% of patients with PRN regimen report recurrence and sudden hemorrhage causing sudden acute vision threatening complications. Also with PRN dosing, you have greater fluctuations in CST. So a greater fluctuation in the retinal thickness is associated with poorer final visual outcome at the end of 4 years, 5 years. So this is a pooled post-hoc analysis of the CAT-E1 and Hawk and Harrier data, which showed that higher CST variability, wherever there was high variability in the central subfoveal thickness, the final visual outcome was poor. So treat and extend is considered best practical approach. But then is it the best practical approach? Because there are some pitfalls of treat and extend as well. So most of all, that you although you need lesser number of injections than what you do for monthly or a fixed dose regimen, but you still will need a lot of injections. So this is almost a 3-year data of a European data from the FIGHT Retinal Blindness Registry of almost 10,000, more than 10,000 patients who were followed up for 2 years. So they categorized these patients into 3 category. One was high treatment burden, one was low treatment burden, and one was the tolerable and the best treatment burden. So in low treatment burden, this was at the end of 2 years, there was a particular segment of high treatment burden group which required injections every 6 weekly. Low treatment burden group required almost about, let's say, between 6 to 12 weeks, and few of them required more than 12 weeks. So total number of injections in 2 years in the high treatment burden group was 19. In 2 years, that is almost every month, 20 out of 24 months, 19 months. In low treatment burden group, it was 14, and for tolerable treatment it was 10 injections. So a number of patients achieving more than 3 months treatment interval where we can prolong the treatment was only 26%. Almost 75% of the people still needed monthly, 2 monthly, 3 monthly injections for, even after 2 years. Again, another point here, that approximately 50% of the patient, they did not even continue treatment after the first year. So those were also not included itself in the study. So most of the patient, they get fed up of the injections. They don't want to take any further injections. So because they have too many visits, poor response. So this is again a very unmet need even with treat and extend. 40% of patients who completed the 2 years still had CNV active at the end of 2 years. So again, you need a more potent drug. You cannot have so many injections, almost 19 and 14 injections in 2 years, and still there will be active CNVM. So that is really an unmet need. So even the study said that you need more potent and longer acting therapeutics. That is why even the FDA has now shifted they're not like entertaining any new drug just for the sake of it. They want only durability now. So this is a data from Hawk and Harrier study which showed that brolucizumab is both more potent and more durable. If you see the change in the central subfoveal thickness, the drug is more potent and you need lesser number of injections. And if you see the variability of the graph, if you see the upper one aflibercept graph, you have a zigzag appearance, whereas in the lower graph, the blue line, that is brolucizumab, you can have a maintenance dose. And if you see that you don't need a lot of fluctuations, you don't have many fluctuations, and this was achieved with lesser number of injections. So this is what a tailored treatment algorithm which I normally follow. I try to follow wherever possible. So you cannot directly treat all AMD patients in the same way. So I've classified, because some patients are very demanding, some diseases are very demanding, some are, they do well. So a type 2 CNVM or a type 3 CNVM are known to respond to all anti-VEGFs almost. So of course, treat and extend regimen would be best, but PRN is sometimes practical in these patients at least, that you can go ahead with PRN. You can use any drug you want because most of them will respond to the therapy. But again, even if you are doing a treat and extend or PRN, with brolucizumab, you will have least number of injection, and it is better for PRN dosing. So in our study, we did a retrospective analysis, and we found that over a period of 2 years, the number of injections required in first year with brolucizumab with PRN dosing was only 4. So then there comes another class that we all know, like they are very resistant. They want multiple injections. They are very aggressive. That is type 1 CNV, PCV, sometimes one-eyed patient, where you don't want to be leave it to a PRN. So fixed dosing is best, but of course it's not practical. If possible, it is the best. Treat and extend is the preferred. I would rather want you to avoid PRN if at all possible, but of course sometimes it is not in our hands. The patient has a lot of other problems that you may end up having a PRN, but treat and extend would be preferred for a PCV or a type 1 CNV. And here also I would prefer a stronger acting drug, a more potent drug, rather than choosing, let's say, a ranibizumab or any biosimilar. I would prefer brolucizumab, either brolucizumab second generation drugs, aflibercept, and then ranibizumab. So for brolucizumab, what I normally follow is I get two doses, 8 weeks apart, and after that I follow them 12 to 16 weekly. They need multiple injections, followed by 12 to 16 maintenance dose. So by this way, you can have about 5 to 6 injections in a year with brolucizumab. So I'm just going to highlight few of my cases here, why early and intensive therapy AMD works. So it's a 47-year-old male, classic PCV with big PED. We can have, so we gave him one injection, aflibercept. We started with aflibercept here, first dose, second dose, third dose. So patient is PED's height is getting better and better. We went for fourth dose as well because you want disease to be quiescent. But even now after fourth dose, his PED in fact has increased. So now we are in a spot, and now we decided to shift the drug, and we switched to brolucizumab. And with just one injection, you can see the effect that we've got a very wonderful flattening of the PED and absolute resolution of the SRF. Also, then he again received another injection almost 12 months later. This was our earlier days with brolucizumab, and he has received just 2 injections post-switch. And also, I feel the early intensive therapy also played a role in this, that there was early very intensive therapy given, which probably led to closure of the polyp. So this is the second case, again, where we went ahead and good early intensive therapy. We can see large PED, PCV patient. We gave him first aflibercept, second aflibercept, third aflibercept. These are monthly injections which are continuing. Then fourth injection, then fifth injection. So after 5 injections, and about 6 months later, we started in December 23, and this is May, last scan is May 24. Now we have the disease quiescence, and at this point of time, we extended the interval. But now we are again back to square one. And this time, again, we shifted the drug and we changed the molecule. We shifted to brolucizumab after a discussion with the patient. And with just after 1 dose, we have achieved this wow effect. So if we this is just 8 weeks post brolucizumab. And if we see the journey of the patient, it took 5 ILIAs in 6 months to achieve from here to here, which was almost similar OCT. In fact, the OCT PED height is bigger in the recurrent scan. And we can see we achieved almost similar result with just 1 injection. So definitely, it's a very potent drug. And we are maintaining, this was in 24, we started this treatment. I just saw her 2 days back, and we advised her now again an injection, and she's receiving now 3 monthly injections. Almost 3 monthly she needs injections. So this is a PCV patient, and you can maintain them at 3 monthly intervals. So that is 4 injections in a year, which is acceptable. Of course, we will want no injections, but it's still acceptable. So what happens when you give in treatment naive cases? So this is again a PCV patient. As I said, we prefer brolucizumab in PCV now. And just 1 month post-injection, you see beautiful flattening and resolution of SRF. But then again, patient gets another injection after 2 months, 8 weeks apart. And after the second injection, is doing very well. And we could extend the treatment interval to up to almost 4 months now. He received the third injection in, after 4 months gap, 16 weeks interval. And post that, I again gave 1 more injection at 16 weeks. Now we can see because the PED height was again increasing in size, although there was no SRF and IRF, but because of the height of the PED, and we knew the disease is going to recur, it's PCV, so we again injected. And so we gave an intensive therapy again here. We did not wait for SRF or IRF to develop. PED height and sub-PED fluid was sufficient enough biomarker for the disease activity. And we gave the injection, and patient has not received any further injections till now. So he just received 4 injections in almost 18 months. So now, of course, the emerging concepts which are coming is port delivery, that the Susvimo has got an FDA approval now. Gene therapy is in the pipeline for both ranibizumab and aflibercept. AI, a lot of deep learning modules are going on for assessing the fluid OCT parameters and counting the fluid in microliters, which will help us in further continuing our therapies. So to summarize, my key takeaways would be that early and intensive anti-VEGF therapy provides best visual acuity preservation. And with AMD, we have to know that we have to explain to the patient that treatment will continue for years. Tailored treat and extend regimen, which I would like to follow, should depend on, we should have certain characteristics like CNV type, which drug we are using, and the patient profile, whether he can afford, and that should be the criteria for having tailored treat and extend regimen. Brolucizumab has a strong drying effect, low durability, and allows flexible dosing, and is more suitable for real world. Thank you.
Thank you, Vikram. One of the nicest talks, practical talks I've heard in recent times is this. So a lot of questions, I think I'll love House also to participate. One or two questions is, you said Q8,
Yes.
2 injections, then
Yes.
Q12.
Yes.
You follow this regimen irrespective?
Most of the time now, yes. With the experience now, yes. In PCV, not in type 2 or type 3, but in PCV, type 1 CNV, I do this now. With the experience that I have gained for 5 years experience, what I have gained with brolucizumab, now I do that.
I slightly do it slightly. I say Q6 for 3 and then shift to Q12 or this thing.
Okay.
So that may be slight variation. And second point is about, you see, like you said, PRN, I think in AMD, PRN has to be discouraged. Always, always.
True.
This is what I tell. DME is okay, you can play with it.
Yeah.
But in ARMD, you...
No, sir, I said, in type 2, type 3, I still feel type 2, type 3 because they respond very well.
Yeah,
So
yeah.
Of course, you should
but
not.
But still,
yes, you should not.
Still, yeah, I agree. The second, that graph which you showed was very, very, worth emulating. In fact, where you showed type 2, I don't care. Type 2, you can start with any drug.
Yes.
Any biosimilar you start.
Yes.
And if it is not, switch after 2 injections. I will switch after 2 injections. I will not wait for 2-3 injections. And in type 1 PCV, in fact, I have been barking for, till the time brolucizumab had come. So right after experience of 13 eyes, we had said that it is very good for IPCV and PCV eyes.
Yes.
And that I think still holds true. And at that time, we had presented 13 patients on experience of brolucizumab. And I am happy that you are having a similar kind of experience. But question to you is that you said brolucizumab / faricimab / aflibercept / ranibizumab.
That
is this the order which you go?
Order.
So that
I would
means
prefer
people who
preference.
are not responding to brolucizumab can respond to faricimab?
Not that way, sir. In the sense that if patient is not willing for brolucizumab, then you go for faricimab. If he cannot afford faricimab, you try Eylea. If he cannot even afford Eylea, then you go to ranibizumab. Go with treat and extend with ranibizumab.
देखो patient की बात अलग है यार.
Yes.
Patient will go by whatever
Then
Vikram
I
says.
have never seen brolucizumab not responding.
I do not give a chance
I
to
think
patient. Patient को chance तो देने का point नहीं है.
True.
Patient will ask you. Patient in this country, believe me, is dependent on doctor क्या बताता है मुझे.
Yes, yes.
If I am telling you, I am a sufferer myself of some disease. So whatever doctor guides me in the best interest, we follow that.
Yes.
Rather than giving a chance, आप बताओ जी आप ये लोगे, ये लोगे या biosimilar लोगे. That is not the best way of treating human eye.
Yes.
So like Dr. Vikram said, I think there will be a very few subset of patients who will not respond to brolucizumab.
Yes.
Like you were saying.
Yeah.
I think out of all the molecules, this is the one which has that, wow effect. Like the pictures you showed, the PED coming down, the fluid vanishing.
Yes.
So you get, and very quick results. So quick that sometimes I think in those large PEDs, you sometimes have to be careful. You may get a rip because it works so fast.
So the
and quick.
buzzword in anti-VEGF era today is durability.
Yes.
Everybody is talking of durability. You see, first generation is 4 to 6 weeks. Once we talk second generation, we are expecting at least Q12 or Q16 sometimes, or maybe more. So the question a lot of people ask me, Dr. Sahab, ये treatment khatam kab hoga? So what do you tell these patients? ARMD, it will be till death or till?
So at present, I give them a 5-year timeline. I don't want to discourage them also. I give a 5-year timeline. That first year, depending on the drug that
Gagan, Ramesh or anybody else would like to. Prashant is here, chairman here. You see, what we are discussing is in an nAMD patient, a lot of people ask, Dr. Sahab, injection, kabhi 6 hafte, kabhi 10 hafte, 12 hafte. Ye khatam kabhi hoga? How do you, this is a very frequent question. Everybody must be facing this.
Yeah, everyone does face this truth and this question. We need to answer not exactly. We cannot be evasive about it just for that the patient continues with us.
Yeah, what do you
we
tell
have
your
to be
patient?
truthful.
What do you
for
tell?
me, I tell them ki, yeah, you have a disease. प्रोबेबली रेगुलर ट्रीटमेंट से आपको आगे चल के फ्रीक्वेंसी कम हो सकती है, पर जब तक आप हो लगने की पूरी संभावना है, बट 70-80% में यू माइट हैव ए
Only
ड्रग
thing
फ्री
is you can reduce the number of injection, not
exactly.
so.
So
You
what
have to
I-
give them
yeah,
some optimism, I
So
believe.
what I typically say, sir, 5 to 6 injection first year, 3 to 4 second year, 2 to 3 third year, again maybe 2 fourth year, fifth year, like that you will need for 5 years at least.
We give them some random statistics by saying almost
Yeah.
30-40% may you can be disease free for a good period of time. So that gives them
So
a
I
ray
will,
of
I will
hope, I believe.
reiterate one thing, that we should discourage PRN in all patients of nAMD, even type 2 also, because AMD is not a forgiving disease, especially, especially PCV.
Yes.
Anytime you can have a hemorrhage,
Hemorrhage.
and you regret. In fact, recently I had one doctor doing very well, 6/6 vision, and for some reason, I was not there, and he came after 2 years with a massive bleed again. So it's
So
not
that reason
possible
also
to.
we are also quite puzzling. Sometimes we keep doing ICGA also 3 monthly, 4 monthly, but still you cannot predict who is going to.
So only thing what I have done in my practical real world is that if patient has 3 consecutive, 6 weekly or 8 weekly visits, similar OCT, similar this thing, you can have a drug holiday. You cannot say we अब इलाज नहीं चाहिए, वो तो बहुत मुश्किल है कहना. Other thing is that anti-VEGF load is not same in everybody. Anti-VEGF load in my eye,
Yes.
your eye may be different. So you follow one size fits all treatment, or this regimen is for everybody, जो भी PCV का patient है, or type 1 CNV.
Sir, ideal तो situation हो नहीं पाता है कभी, because of course lot of variability is there. But if I want to do it for my eye, maybe probably I'll do that. But of course there is a lot of variabilities, lot of factors, logistic issues. But if you ask like that, for PCV I would like to follow this, because we have had instances where certain hemorrhages occurred and then the vision is lost.
What about PAEHCA, peripheral exudative, variant of PCV which is in the
So we
periphery?
try to do laser and not just one anti-VEGF laser, not much.
Sometimes.
Yeah.
Yeah.
So do you
Sometimes they do
Self
need
resolve.
more injections, PHCR,
Yeah. PHCR is often an undiagnosed or underdiagnosed entity.
underdiagnosed.
You see, other last question for everybody is, you see, you show 2 examples of switch,
Yes.
1 patient of naive.
Yes.
So, and all of us believe, Tinku just said that, it's a very potent drug, durable also. Why most of us, most of ophthalmic fraternity, most of retina, VRSA members also, they will switch, okay, but they will, treatment naive, they will always have fear. Why so?
I think that
Because everybody says it's very potent.
Yes.
Everybody, is there that fear
Because,
of IOI or
earlier,
vascular?
of course, sir, that is the biggest fear that everybody has. But fear is, of course, but we have, touchwood, never had such phenomenon. And in Indian eyes, we did a study also that there are very few, only 0.9%. And out of those 0.9, also 0.7 were mild only reactions. We have had mild reactions, but we've never had any occlusive. What everyone is afraid of is occlusive vasculitis, that we have had reports of European countries and American, and that there was complete occlusive vasculitis which has resulted in loss of vision, which of course everybody is afraid. I believe sometimes even Novartis also has little apprehension about it. So that does play a role in that.
So I'll
But
ask this question to all 5 of us, Gagan, Tinku, Prashant, and
I think that is the only rate limiting about
You
it.
see, people are so confident that they'll switch after 2 injections, that there is a reason, na, bhai respond nahi kiya to you
Yes.
switch.
Yes.
So then that fear also may be slightly subdued, but Dr. Saab ने मुझे समझा दिया था, वही इसलिए कर रहे हैं. But treatment naive, an ophthalmic friend comes to you. What do you?
Sir, to be precise, I have changed my protocol. Somehow I have gained a lot of confidence with this molecule. We started using early, we were amongst the early users. And I think we are having a lot of skepticism because of the fear of IOI, which is, I think, overhyped, I believe.
Yes.
In my experience, probably where we use about, I should say about 300 injections per year. And in last 4-5 years, I might have completed about 1200, 1500. Touch wood, I didn't have any occlusive vasculitis. 1 or 2 cases, we had mild inflammation, which happens with any of the anti-VEGF. So we don't need to worry about. And regarding your first question, whether do you use in a naive cases? Yes, of course. We are using at our center in naive cases also. we give them a choice of a bouquet of choice of various anti-VEGF molecules. We tell them very precisely, see, any ranibizumab or anything, you will be using this molecule at 4 weekly intervals. So in a year, you might end up in the first year needing 8 to 10 injections. While with this molecule, you might end up needing 3 to 4 molecules or injections only in a year. And many of the patients are ready to pick up this particular theory of it. And this is important basically because the context in which we are placed in Indian countries, where we are placed in economically backward zones of our country, money is the most important factor in deciding the molecule besides the whatever we as a surgeons propose. So I think it is ill-profounded, unnecessary fear that we are not using in naive cases. I do use it.
So you think that, you see, everybody wants the most potent and most durable.
Correct.
Nobody wants the least potent and
Very true.
less durable.
Very true.
So should we throw away all other anti-VEGFs?
I would not say that. See,
No, reason I'm asking is, dekho, it's a practical world.
yeah.
Patient wants the best, patient wants the most durable also. And if you today say that this is your choice in treatment naive also, then where are we?
Exactly. See, sir, we need to understand we cannot treat the patient in separation. We need to understand his socio-economic as well as his financial status while making a decision.
The reason
for the
I'm asking
molecule.
is that, Professor, he uses Zydus ranibizumab.
Okay.
The reason I'm asking, suppose, it's a theoretical, suppose this was a very low price drug. Instead of giving it at whatever price they sell it, I don't know. But suppose it was a low price, say 10,000 rupees, or will it become number one?
I think so. I think
It
so.
will
For
definitely, sir.
majority of the
Definitely it
indications,
will.
of course.
Ramesh?
Of course.
It will.
Yeah.
Because I have a very different mindset in this, that you want to treat with the best drug so that it has got the best.
Best is relative. What is
No, no,
best?
best is something which will retain his vision it will help in
So
reducing
what is the best according to you?
in AMD management.
Yes.
In AMD management, if you ask me, it has to be brolucizumab because of the wow effect which it initially produces. See, a patient is very upset that
Not faricimab.
not faricimab.
Why?
Okay. Faricimab efficacy wise, it's yes, but durability wise, because when the drug was marketed to us for faricimab, it was marketed on the durability and the extended durability of 16 to 20 weeks.
Yeah.
Understood? And that has failed. To be very frank, that has failed in the real world situation where it is not able to reach 16, 12 to
Efficacy
20.
wise, it's equivalent.
Efficacy wise, yes, it is quite comparable. But even in terms of PD resolution, brolucizumab is the best drug,
Far, far better.
far
Far
superior
better.
than
Yes.
faricimab.
Totally agree.
Tinku, your take?
So again, like I said, it is one of the most potent drugs, and in my experience also, I've not had any serious IOIs. I think we need to be vigilant. Why patient selection is very important. Like patients with a history of uveitis, we should not take them up. Also, a close follow-up of patients. Like I would call these patients the next day. In the beginning, when I started using this, I would call them the next day and be in touch with them over the phone. But over the years now that experience is built in, I'm more relaxed. So I think it's a wonderful molecule. Gives us the best results. Gives us durability. And safety, of course, there are a lot of studies now in Indian eyes, and our experience also has borne that it is a safe drug. So
Yes, Gagan.
it is
So I just
my
wanted
drug
to
of choice.
ask,
Ramesh,
I
you
mean,
can- Ramesh, you
there
can
is no
agree.
doubt that brolucizumab works very well and it's extremely potent. But as Vikram also showed these cases, so do you have any difference in your first line of management when you have a very high PED with the risk of RIP?
And
Would
that
you
is-
go in for a smaller, a less
No,
slowly?
my drug of choice in symptomatic PEDs required treatment is brolucizumab. And, there's no ambiguity about this. And it really works in flattening much more than, as Prashant was saying, much better than any of the other drugs.
No, but what about risk of
RIP,
RIP?
In fact, we never had, sir.
Never had.
We've never had. So I've tried to make a hypothesis around that also. Maybe it is such strong acting that PD is getting flattened, it's not getting ripped, and rather than the tractional forces of that is the more responsible for PD. So a slow thing is, we never know what is causing, but we tried to analyze how many rips did we get. We never had a rip.
You see, RIP can happen after treatment, RIP can happen spontaneously also, RIP can after PDT also, RIPs can happen. So to blame a molecule for RIP may not be.
No, that's perception that a high PD will rip.
This was there
It's
when the
not
drug
there.
came in.
Just
I
make
think
a
a lot
small
of us were skeptical that it would
Yeah,
cause a
yeah,
rip
yeah.
since it was
If
so
I could just make
potent.
a small comment
But
in
I
Vikram's
think
case with
I
that
haven't
large
seen that
PED which
happening.
flattened, I think there was a rip which has
So I
actually
also,
flattened.
because the ultra that
Because
IR
you
image
add
shows
overlying
that,
strem over it.
the IR image shows,
So that
suggests
said that it is
I
not
went
a
back and
flattening of
saw
the
it
PED,
again.
it's a rip which has caused the flattening.
So I've again went back and seen it's not that. There's no rip in that.